Okay, so as I promised, I'll give you a brief background on the DHIS tracker. DHIS tracker is the part of DHIS that deals with individual records, sometimes called transactional data, sometimes patient data, sometimes it's anonymous data. But it's a relatively new component of the DHIS tool. So during the presentation and during the practical assignment, you will see that not all parts of it are as stable as the aggregate part of DHIS. And this is a great opportunity for us to get rid of a few more bugs. So bear with us and please report all the issues you have during the practical assignment. And then I'll try to do my slalom skiing between the bugs in the presentation. And we'll see how it goes. So the first question is why? I mean, why did we start on this track down to patient data, individual records? The first requests that came from many of the DHIS implementations that we're using DHIS to was the request to be able to drill down from the aggregate numbers into the, if you can visualize in your head the summary reports and then the register, sort of from the aggregate data in the summary report into the each and every line in the register, into the cases. Being able to drill down and see more detail about what is behind each number in the aggregate summary report. This is, to me, a very typical HMIS approach to transactional data. It doesn't have to be, as we will see in Olav's presentation later, it doesn't have to be patient data. It can be anonymous. It can be data about a visit, an outpatient event. It can be data about an inpatient admission, but it doesn't have to have the person details. It can also be data about a cholera outbreak, a specific case with lots of details, not necessarily including the names. So that was one request. And then, in addition to that, you had many program officers that were interested in being able to address the problem of dropouts in the programs. So you have, from the maternal programs, you have the antenatal care, delivery, postnatal care, longitudinal program, you have child care, all the steps to immunization, growth monitoring, nutrition. And then you have, of course, the more protocol with TB, HIV, where you have repeated visits. But the idea is to be able to make sure that your clients come back for the next stage, the next visit in that program. So this is also addressed in the track, and that is the use case I'll use in my practical demo a little bit later. And then, of course, this combined with the increased availability of computers at the facility level, at the clinics, and also the mobile internet. So more and more facilities are connected. And of course, when they can log on to a system and enter aggregate data at the end of the month, it's a natural question, why can't I use the system every day? Not just in the first few days of the month. So, all in all, there was a push for extending DHIS to deal with more transactional type data. Not necessarily a very complicated clinical support system for one clinical setup, but taking a program approach, taking an HMIS approach to it. Someone calling here, Lars? Okay. So the first, I have listed 5 use cases that I'll go through here. There are many more. I think we have this one recorded before. Yes. So the first use case is the what we call case-based data collection and analysis. So this is, my first bullet in the previous slide is, being able to drill down into sort of line listing style of data. So that could be to capture an OPD register or the inpatient register with detailed data about each visitor. These A3 books with all the columns and all the events taking place. It could also be, as I said, some kind of vital event or outbreak. It could be a cholera outbreak where you want to go out and investigate and fill in a form with some more details. And then the idea then is that you can do a lot of aggregation on this side. You can get more detailed aggregate data, but by looking at multiple factors in one case. And then, since DHIS is an aggregate system, the benefit then is that you can set up links between this case-based data and the aggregate data. And then you can do this automated aggregation. So every night you can produce new statistics, new aggregate numbers based on the newly arrived transactional data, cases coming in. Okay? And Olav will show you in his session how you can set up these queries and do some analysis, both on the case level and also how you bring that into an aggregate concept. So one advantage then when you, for example, when you do IPD, is that you can get a lot more details. Huh? You can instead of, if you think of this monthly summary form, disease surveillance, the form that never changes. The 50 diseases defined in 1960 and then never changed, and then all others keep increasing every year. So you have a very static way of reporting mobility. But if you do the cases here, you can have one column or one field of data element in that patient or transactional data collection, where you can have the ICD-10 code with a drop-down, and you can search for the code you want or the disease you want, and you can fill in detailed data about the diagnosis. And then at the end of the month, you can then produce very detailed top 10, top 20. You can look at what are actually the diagnoses used, and then you can also then influence the monthly summary form and update that to actually have the relevant diseases. Olav's use case is exactly about that. And this doesn't have to have personal details. It can be completely anonymous. To get detailed research analysis on the morbidity and the diagnosis, you don't need to know the names of those persons. You just want to know how many of this and that category. So this is used now in Ghana, all the district hospitals. Olav, also how many cases are coming in every day, more or less, from the district hospitals?
I checked since April 2012, there were 550,000 cases.
Yeah. 500,000 inpatient records. That's a lot. And I've seen some of the summary reports, aggregate data with detailed analysis on diagnosis. I think we'll get the chance to see that later today. Kenya is also going for the same approach with anonymous inpatient cases from district hospitals. Okay, so that's this case. And then a second case, which is very similar, is the example of doing death audits or verbal autopsies. So you can have a lot of details about one vital event, one neonatal death, one maternal death. So, for example, in Uganda, we set this up. It was a 5-6 page long maternal death form where you fill in all the details about that deceased woman, with the antenatal care history, with everything that happened during delivery, of course, causes, indirect causes, all this. And then, so all these are then sort of what we call patient data elements, hundreds, and then you can set up queries and really find out, are there some linkages here? Right? If you look at 1,000 deaths, then you start to see some patterns. Why are these? What are the major causes? What is the history then? and then do a lot of statistics on this. For example, you can then generate easily a top 5 direct courses or whatever. So that's another use case. And then the use case I will do in detail a bit later is the program perspective, program manager perspective. Being able to define steps in your program that all the clients have to go through, and then enroll your client, schedule these events or steps, and then being able to track who is not coming back. Even sending out SMS. You can send out reminders 1 day before, 3 days after. Why didn't you come? Please come as soon as possible. You can start to do, I'll show you later, some listing of the ones that are missing out, etc. So that's a way to get rid of the dropouts. You can also, in this use case, have a person dashboard so that when a woman comes for an active care visit, you search for her in the system, you find her, and then you'll get sort of overview of her pregnancy with the data for each case, each stage, her demographics, and certain details. I mentioned in the implemented story session briefly that we are working on such a use case in Norway with the Norwegian Public Health Institute. And they have a very clear idea of exactly how that person dashboard should look like. So what I'll show you today is the standard way, which should fit, most, the 80% of the use cases. And then you can also make apps. And that's what we're doing in Oslo. We have a developer that's making a custom app which is completely tailored sort of person dashboard. Using the same code underneath, but having a different way of visualizing that data. I think you will see more of that app later. Okay, now more, at least immediately, a bit more far-fetched case. I think it's important to look at Tracker as a way of dealing with not only patient data, but transactional data, discrete data, more detailed data than aggregate data. So what we, WHO has this SARA tool. So I'm sure that some of the countries here have done the SARA facility. It's service availability and readiness assessment. So it's a very detailed assessment of the state of each health facility in the country. In Kenya, we set up sort of a Kenyan version of the SARA tool using DHIS tracking. The idea is that while this is definitely not about persons or patients, it's about collecting detailed data and also the type of, the way of collecting that data makes it quite suitable for tracking. So that if you think of the survey with lots of questions and then lots of options for each question, so you have sort of a list of predefined text values that you want to collect. So typically, I mean, one example is, do you have access to internet? And then you say, no, yes, I have mobile internet, yes, broadband, yes, in the nearby internet cafe. So you have different options or different answers. And then that's for each facility. So when you move up to the district level, you want to know, okay, how many facilities do not have access? And then you have to start to count these answers. That doesn't really fit well with the aggregate way of collecting data, but it fits well with the sort of two-level, having transactional data with the text-based answers, and then having aggregate data, counting how many of each. You see, so how many facilities replied no internet, and then okay, 6 facilities you have. And then you have your 20 facilities, and then you can start doing indicators in the aggregate system and get percentages. And as you move up, then you have complete overview of number of facilities that replied, to different answers to the different questions. So you can do survey in track. one example I've used here is the basic emergency obstetric care. Yeah.
Can I just yes.
Yeah.
So your reporting unit then would be the org unit.
Yes, the facility.
And you're actually only using the tracker because you're wanting to count text-based values.
Yes.
That's the only reason, really.
Yes, and it's actually, also in Ghana, this inpatient is using the facility, and then a list of, we call them patient data elements, but they're not really patient data elements, but no person. In that inpatient register, there's no person in the system. You don't register the person. We don't make use of what you have in the data model, the person object. There's no patient in the picture. So it's the same thing with the SARA, is that you have you define a form, your survey form with all the data elements and the options for each data element, and you link that to an org unit, and you have a date for that, and then based on that you can start to do aggregations.
And then how do you manage having repeat surveys?
Yeah, no, that's good. You have more? No, I think that's luckily they don't do SARA that often. So no. You have dates, so you can have dates for the each instance of that survey would have a date, and then you can define, when you do aggregation queries, you can sort of define ranges, and then whether it's quarterly or 6 monthly or yearly. I think that. I mean, to be honest, we haven't had any examples where they have done the SARA twice yet. Because WHO typically funds that every 5 years, and countries are not that good at taking it up. But I mean, it's definitely doable to say, if you agree that you have this every year, then a survey taken within the boundary of that year would go into that aggregate data for that year, and then if not, it would go to the second. I mean, that's one way of doing it. I think that we can definitely sort of make that easier, improve that a bit in the aggregation period.
And then what tool is WHO actually using? What have they got for their SARA database?
Yes, I think they have one is it CS Pro, one tool that they use, but I think also it's really up to each country to decide whether they want to use existing data collection tools for this. But I know WHO has a CS Pro software that they can use. The problem is that it isn't linked to any of the service data. So the advantage of doing this in DHIS would be to being able to actually aggregate those statistics and then correlate with the monthly service data coming in and do more. You can use it as a lot of denominator data is there in the survey. Any other questions on this survey? No? Good. So, the fifth use case I call educational events in the community. This comes from PSI, Population Services International. Juan is here representing them at this workshop. I worked with Rodolfo, who has been designing a lot of the information systems for PSI. I'm not sure that you actually end up doing it exactly as in my slide, but these were some of the ideas we had when we went through these requirements. This could be at least one way of doing it. So let's say you have you do family planning interventions. So you can do longitudinal tracking of family planning. You can follow, you can do all the use case. For example, you have this, you hand out a voucher. That could be step one, when they cash it in and get the service at the facility. It could be step two, and you could have, that's one way of doing it. You also could have the typical monthly family planning, so you can see the uptake. But then you can also have educational events. You can do a speech at the market, townhouse, in a park, educating the target population about family planning, why it's useful. And then for each of these events, you could, for example, you can record geo coordinates, so the exact position of where you did that, educational event. You can also collect, how many women attended, how many men attended, what was the topic of the day, these details. And then when Jan is done with his GIS for, is it 14 or probably 15? 14? Wow. I have that coming soon slide for a while now, that's good. You can, today in today's source of DHIS, you can collect the coordinates for each event, but yet you can't see it in GIS. But that's coming in the next release now. Lars confirmed that you can then visualize on the map the dots where you did events, who you targeted, and then you could put a layer on top of that showing family planning update in that area, in that district, and you can start to look at the effect of your educational events. That's one example. And of course, the GIS part of this you can also use for the the cholera outbreaks or for other vital events. This I also put here that you could actually enroll the educator, the guy working at the district for PISA. He could then be the one that's enrolled into the program. You can schedule the events, that's sort of his work plan, and then you can also do performance on your stuff. See what they're doing and planning the events. But that's definitely an optional component of this. The idea is that you can capture exact coordinates of events, put it on the map, and start to correlate with all the data you have in the system for that area. Did that make sense? Yeah. You want to comment one? Maybe
there's a new use that we're going to start in Ethiopia this month, actually, to track training sessions for PSIs and local implementing partners to make sure they get the training they need to work with the clients and track advance in different levels of training sessions to make sure they complete all the sessions with specific scores and in the order that is specified in the program. So it's not only involving the educators, or the peer educators, it's also internal people getting trained.
And that you will use tracker for?
Yes.
That's interesting. We might use case number 6 next presentation. Yeah. That's great. Okay, so this is a bit early, but I'll bring it back later when we start to play with the system as well. Since you will be designing programs today, so it's good to have a little bit of an idea of the concepts that you're going to use. So okay, let's visualize the ANC, the Antenatal Care Program. So you start. This is the placeholder. You have the Antenatal Care Program. You can split up into stages, which are typically then types. To make it a bit more complicated, it's a type of visit. So you could have multiple visits for one stage as well. But let's say just make it very simple: ANC1, ANC2, ANC3. It could also be ANC1, all revisits and delivery. But that could be another way of representing it. Each stage is linked to a set of data. So if you think the aggregate system, the stage is also a data set. So it has more information, but it's also a data set. So it's made up of data elements, and with those data elements, you can also define, for each data element, the options, like I talked about in the survey. So you can define, I don't have internet, I have broadband, I have mobile, internet cafe, for example. So this makes up a form. So you can sort of generate your data entry collection tool using the program stage. And then a person, if it's Antenatal Care, then you need a person, is then enrolled into that program and will be taken through these stages and then have sort of an instance, as we say in the computer language. They will actually do a visit, an event, and fill in, for each stage here, you will then fill in a new form for that visit, linked to that person. Okay, I'll come back to this later. I just want to add one slide on important area of course, when you work with personal data on the security and the privacy. There's a lot of discussions on our mailing list and also internal mails in the community about this. And I think it's fair to say that we are quite new to the whole concept of collecting patient data. So we have room for improvements. As you see, there are a few coming soon here on this area, especially on, I guess, documenting on the website and in the manuals, implement the guides, how we deal with security and privacy, and guidelines, best practices for setting it up. I think one thing is very important to understand, as you know, as the implementer, is that DHIS is very generic. You can customize it, tweak it in many different ways. So we can put as much encryption and security we want on the server and the traffic. But if the main guy, the administrator, creates one admin role with access to everything and gives that user role to everyone, they will see everything. So it's really up to also the person implementing, customizing DHIS to make use of the different techniques we have put in place to protect the data. So you have a lot of user role, you have authorities that you need to set up and to make sure that you control which user can access which part of the system. So you don't want the guy doing the inpatient data to be able to see the persons enrolled in the ANC PFC program. So you can define detailed access rules, access control through the user roles and the authorities. That's one way. You also have, as you'll see when you're in the person dashboard, there's a log. You can see who has accessed this record, this person dashboard before. The SSL encryption, it's given that, of course, you need to encrypt if you have an online installation, but that's on the server side. How you set up your server environment, that's sort of outside DHIS, but definitely something that must be in place to encrypt the traffic. So you'll have the HTTPS, not the HTTP, when you log into the system. Coming soon, database encryption on personal identifiers. We are working with PSI on this. Hopefully now that's also 14. Let's see. It's been a bit delayed. It's a bit complicated, but the idea is to be able to encrypt in the database all the elements that can identify a person. So the person attributes like name, address, all that, and of course the identifiers like national ID in that part, and then make sure that you completely then disconnect that data with the data that took place at the event. For example, HIV test positive, and then the name. You disconnect that part so that you can't, hack. If you get a copy of the database, you couldn't make sense of it, linking the persons and the data. Okay, so that's it. I think we are very interested in having input from you on this. If you have experience with this, we are working with, as I said, the Norwegian Public Health Institute also. They are bringing in a lot of experts on this, so they are trying to, provide policies, etc. What is complicated is that there are very often not very clear policies on this side. There's a lot of discussions. So even in Norway, it's a bit unclear what exactly the policies are. And of course, we are working in many countries, so we need to find a set of policies that can meet at least the common denominators from all countries, and then being able to build on that so that each country can implement their own policies. Okay. Any comments on this? Yes.
Can you please go to the slide?
The model.
Yes, this one. I was just thinking, is it possible to introduce the log mechanism that we have on the analytics and data set on program 60 stages?
This is just very, this is very high level, conceptual drawing. There's a lot of functionality in there. You want to lock data entry?
No. I was working in a community program whereby what they do is quarterly.
Yes.
After a quarter,
Speak up.
okay, I was working in a community setup whereby what they do is quarterly. And after a quarter, they are expected not to be able to enter any data for that quarter.
Yeah.
So I was thinking if it is possible to lock it, so they cannot enter names or anything.
Yeah, you can do it. We'll do 3 hours of live demonstration on that, a lot of detail. So you will see a lot more what can be done. This was just a conceptual drawing, so that you start to understand that it's on this. Okay, but I'll come back to that. But the answer is yes. You can block editing after a certain time. Yeah. Okay. I think it was my last slide. So, yeah. Just want to give you this. I thought I modified this link. It's actually not the right link. If you go to DHIS2.org, I'll distribute the slides with the correct link to that. It's individual -data -records, but there's a link. If you go, you will find out that there's a link to actually a page with all the overview of Tracker, the features, and all these use cases I mentioned here are listed in more detail. If maybe I can show. I have this on the tab here. So you have this page. So this is the correct. But you'll find that on the slide later. You don't have to open this now. So this is an overview of the functionality, and then you see there's much more on each use case, trying to describe a bit more. Okay, so that could be a useful reference. And these are just examples. Huh? As I said, it could be many others as well. Okay. I'll take a very short break and then prepare for the next one.